Hey A&Pers, this is Dr. Jones checking in. This is A&P 2 Lecture Test 4 Video 9. And I have us at the top of page 14, which for me looks like that. So I'm actually going to just leave this here for a second, so y'all can see how I've drawn it. I will draw us this on a whiteboard, but as you can see, it did not stick in the spot that I made for it. So, sorry. Okay, so we're top of page 14. By the time it reaches the pulmonary veins, the PO2, actually I think this is the previous picture, the PO2 and the PCO2 are at equilibrium with alveolar air. Did I not say that at the bottom of the last page? I feel like I just said that. What happens when the oxygenated blood hits the systemic capillaries? Now I need the next picture. So here's external respiration getting the oxygen into the bloodstream, and here's internal respiration where the oxygen leaves the bloodstream. So when we hit the systemic capillaries, the oxygen diffuses out and the carbon dioxide diffuses in. And then diagram the internal and external respiration shown in this picture. So let's up W. There we go. Okay, so let me get the black. And I'm going to draw us a ring of blood vessels. That's the blood vessels. And then right here is the heart. And then here again is the heart in our circuits. So this side is going to be the systemic circuit. Systemic circuit. And then this side will go to the lungs. Pulmonary circuit. Okay, so here, like that picture, I'm going to draw how I always draw the little guy, little person, and then draw more specifically some cells. Little fat cell there, cuboid cell, a couple of cuboid cells. And we'll throw a smooth muscle cell in the background. Okay, so clearly this is cells of the body. And then here, I'm going to draw my terrible rendition of lungs. Yep, that was terrible. And over here, I'm going to draw an alveolus. Picture of one alveolus. Yeah, I just had one alveolus. Okay. Oh, I just deleted it, didn't I? Derp. I can't go back to it, can I? It's just gone. Yeah. That's terrible. Yeah, it's gone. Again. Up. W. Okay. Maybe the drawings will turn out better this time. Okay. Heart. Body. Heart. Lungs. Oh, cardiac notch. There we go. Okay, so we have an alveolus. This is the pulmonary circuit, systemic circuit, and then we got a couple of cuboidal cells. We got an adipocyte. and a smooth muscle cell in the background. Well, it's not worse. I don't know if that's better, but it's not worse. So let's start with our oxygen. So at the lungs, oxygen enters the bloodstream and the pulmonary veins are oxygenated. And these are the systemic arteries. They are also oxygenated. And at the tissues, we will drop off the oxygen and pick up, switching to blue, carbon dioxide. And there is carbon dioxide in here, but not nearly as much. Okay. So carbon dioxide to the heart. So these are the systemic veins. And then the pulmonary arteries, which are deoxygenated. And then excess carbon dioxide enters the alveoli and you exhale. So that's how that works. So oxyhemoglobin is hemoglobin with an oxygen. You recall oxygen without a hemoglobin is deoxyhemoglobin, and hemoglobin with a carbon dioxide is carbaminohemoglobin. Because that's fun to say. All right. There's the picture. Moving on. So the oxygen hemoglobin saturation curve is this thing. And this graph shows that the hemoglobin saturations at different partial pressures of oxygen. And binding oxygen makes it easier for the next hemoglobin to bind more oxygen. So when you increase the partial pressure of oxygen, more oxygen binds to hemoglobin. When you decrease the partial pressure of oxygen, less oxygen binds to the hemoglobin. Describe what happens as oxygenated blood passes through the capillaries in inactive tissues. The hemoglobin drops off about 1/4 of its oxygen, and it keeps about 75% of the saturation oxygen reserve. When you use less oxygen, it drops off less oxygen. In active tissues, of course, it drops off more oxygen. Active tissues receive 3.5 times as much oxygen as inactive tissues. When you use more oxygen, the lower oxygen levels makes more oxygen drop off of, because as you get to a lower partial pressure oxygen, it holds less oxygen, and so the oxygen falls off into the tissues where you need it. So it's actually pretty cool. If there is too much carbon dioxide, the pH is lowered. Lower pHs, more acidic. And that causes hemoglobin to drop off more oxygen. So that's handy. This is called the Bohr effect. So when the pH drops, as in active tissues, more oxygen is released to the tissues. And then lack of what compound can make stored blood useless after a time, and that is BPG. Technically, that is 2,3-biphosphoglycerate, which I will never ask you to spell. At these same partial pressures of oxygen, fetal hemoglobin binds more oxygen than adult hemoglobin, which allows baby to suck all your energy. So that's why. I believe we've said several times already. Carbon dioxide, page 15. I'm going to try to finish respiratory in this video, so we need to start digestion. I'm going to get respiratory out of the way here. Carbon dioxide is transported in 3 ways. It's transported as carbonic acid, carbaminohemoglobin, and dissolved in the plasma, which are reversible, all 3, fully reversible. And carbaminohemoglobin is how you spell carbaminohemoglobin. And that's, of course, carbon dioxide bound to a hemoglobin. And then we're not memorizing all of this, but that's how it works. How you breathe. The respiratory centers. Respiratory rhythmicity centers control the respiratory muscles and therefore the respiratory rhythm. So there are respiratory rhythmicity centers that set the pace of respiration. They are in the brain stem. Most of the unconscious things like the breathing and the heart rate are in the brain stem. The dorsal respiratory group is the one in the back, dorsal. It's the inspiratory center, so it is active with each inhale. If you damage your dorsal respiratory group, it will, because this activates your diaphragm and your external intercostals. The dorsal respiratory group controls your primary muscles of respiration. So without this, it's hard to breathe. The ventral respiratory group is in the front. It controls all of the accessory muscles. So it has an inspiratory center that controls the accessory muscles of inspiration. So the serratus anterior, the sternocleidomastoid, the pec minor, that all pull the ribs up and out. And also the accessory muscles of exhalation are controlled by the expiratory center of the VRG, and those control the secondary muscles of expiration, the abs, the obliques, the internal intercostals. And then I have a chart for you that I think says everything we just said. Oops, that didn't work. Does that work? Hyperpnea. Okay, you've seen it. Eupnea, inhalation. Eupnea, inhalation is active, exhalation is passive. Inhalation, the DRG is active, it controls the primary muscles of inspiration. In exhalation, the DRG is inactive. In hyperpnea, inhalation is active. This is active forceful inhalation. This is active forceful exhalation. Active forceful inhalation, the DRG is active and the VRG inspiratory centers are active. The DRG controls the primary muscles of inspiration and the VRG inspiratory center controls the accessory muscles of inspiration. And then in hyperpnea exhalation, this is active forceful exhalation, blowing out the candles on your own personal birthday cupcake. Because ew. The VRG expiratory center is the only thing that's active because it controls the accessory muscles of expiration, including the abs, the obliques, and the internal intercostals. All right, continuing this page, sudden infant death syndrome, SIDS, also called crib death. The previous edition of the book said it killed 10,000 babies a year in the US, and that number has been decreased in this book to 2,250 babies a year in the US. And it generally happens between 2 and 4 months, and it disrupts the normal respiratory reflex pattern. It's connection, they think it's connection problems between the pacemaker complex and the respiratory centers. So controlling the breathing and the heart rate at the same time is tricky between the ages of 2 to 4 months. And part of what happens is if baby is asleep too deeply and they aren't breathing, they don't wake up. If baby isn't as deeply asleep, then they're more likely to wake up. So one thing that they recommend, never ever put baby to sleep on their tummy. They used to recommend, oh, put baby to sleep on your tummy because they sleep deeper, they're less likely to wake up, but more babies die of SIDS. So we put the babies on their back or on their side, not like up on their side where they're gonna roll over, but like kind of wedged on their side, and they make like baby wedges. And like you put the baby wedge under and so that they're on their side. And you never have pillows for littles, for newborns, because if they get suffocated in it, they can't wake themselves up yet. And no heavy blankets. That's why they sell those sleep sacks for babies, because You can't put blankets on there. The crib, the little fluffy things that go around the crib so that they don't hurt themselves on the crib walls, those are junk. Throw those away. Because babies, again, can get caught in them and can't breathe and can't wake themselves up. So breastfeeding lowers the risk of SIDS death. It doesn't eliminate the risk of SIDS death, but we can do something to help. And room sharing lowers the risks of SIDS deaths. If they're in the room with you and they stop breathing, you can hear it. So being in the room with you is preferable for this. Also, if they wake up and they want to feed, they're not like screaming by the time they wake you up and you get the other end of the house. So let's continue to decrease the rates of SIDS deaths. And chemoreceptor reflex. I apparently don't have a slide for this, so let's go through it. High levels of carbon dioxide and low levels of oxygen increase the rate and depth of respiration, and of those, the carbon dioxide levels are more important. And hypercapnia is high PCO2 in the arterial blood. Hypo is low PCO2 in the arterial blood. Hyper is more, hypo is less. Hypoventilation and hyperventilation. Hypoventilation is a low respiratory rate. Hyperventilation is hyperventilation. Hyperventilating, where you're breathing too much and you have too high a respiratory rate. When blood pressure falls, the respiratory rate increases. When blood pressure rises, the respiratory rate decreases. The Ewing-Bauer reflexes, in hyperpnea, they prevent overinflation of the lungs. They also prevent over-deflation of the lungs. So, sneezing is triggered by irritation in the nasal cavities. So that's why. Coughing is triggered by irritation in the larynx, trachea, or bronchi. Apnea is not breathing, like sleep apnea is not breathing in your sleep. And laryngeal spasms are where the larynx contracts and that closes the glottis. There are some chemicals apparently that can cause laryngeal spasms, and that's it. You just never breathe again. That's terrifying. What happens when you hold your breath too long? You pass out and then you breathe. So my younger did try this when she was little because she is intent on getting her own way. Well-behaved women rarely change history. So she was like, if you don't, whatever it was she wanted, I'm going to hold my breath. And I was like, all right. And I made sure there was nothing around her that she could hit her head on. I think she had happened to have pillows behind her anyway. So I made sure she was safe. And I was like, I'm just waiting because I've never seen somebody hold their breath until they pass out. So I was like, oh, this is awesome. Go for it. And it occurred to her that she wasn't going to be able to use that to get what she wanted. She never tried it again. So, but once you pass out, you breathe. So, there you go. Why is smoking bad for you? It decreases respiratory function over time. So the blue line is without smoking. Respiratory function decreases over time, period. And with a regular smoker, it decreases over time. We cross into disability-ish around 60. And, oh, that's not good. And if you stop, then the earlier you stop, the less bad it gets. So it's always worth it. Okay. All right, so we will start here with the next video. This has been A&P 2 lecture test for video 9. And we did 14, 15, and 16. 14 through 16. Okay. Thank you as always for tuning in. The education must go on. Dr. J out. Maybe I can do it this time. Think? Maybe not. Okay.